Thank you very much for the introduction, Cha. I'll share my slides here. And thanks everyone for attending. So this presentation is about the Open Care Asia Platform Cooperative, an initiative that we started talking about and then specifying in August last year, and just since evolved. And today, what I'm going to do is to provide an update on where we're at and where we're going and how you can participate, and hopefully we can entice further jurisdictions to participate in this wonderful initiative, which is about the systematic reuse of best practices in healthcare service delivery. So what are we covering in this webinar? What we've been doing and what we are doing is translating collective knowledge into human-scale tools and local clinical practice. So we'll start with a brief introduction to the Open Care Asia Platform Cooperative. We'll present initial domain analysis results that we've been conducting with participating stakeholders in the Philippines. We'll outline the process for jurisdictions to join the initiative. I'll talk about the co-funding model of the initiative, which actively encourages collaboration across Asia and collaboration with a diversity of co-funders. Then I'll explain how the approach we're taking provides a stable baseline level of funding that avoids the risks of depending on a single potentially volatile source of funding. And lastly, and perhaps most importantly, we want to have an interactive Q&A where the current team members are participating, both from S23M, so that's our worker co-op, and from interested participating stakeholders in the Philippines. And you're invited to ask questions, and we hope to respond and encourage you to join. So why is a regional cooperative the best model for health IT? Well, I think the answer should be obvious, or is obvious to us. It is via AeHIN that we've got at our disposal, I think, an enormous regional domain expertise and collective tacit knowledge within the COIL network, and this allows us to address wicked problems that no country is in a position to tackle in isolation. No market or EMR vendor has an incentive to tackle, and there's no vendor consortium developed technology standard that is equipped to handle these wicked problems, and no university is resourced to tackle these things either in a timely manner. So what we've been doing as a company for over 20 years is enabling knowledge to flow to all the places where it can be put to good use, and this is exactly what we are doing with it, this initiative as well. So this is about making the world a healthier place for everyone. So we recognize that we all thrive when given the opportunity to work and connect with our most trusted peers. In good and honest company, everyone is acutely aware of all the collective diversity, intelligence, and capability that are available in the form of a trusted community that includes all contributions from all colleagues, friends, whānau, and family. So in Aotearoa, whānau stands for the extended family that goes beyond the small families we're used to in the Western world. And cultural and psychological safety is about exercising the ability to act in good faith, respect, and acknowledge the diversities of all people. In our times, I think we're all becoming conscious of human cognitive and emotional limits, and we recognize that these limits are just as real, immutable, and relevant for our survival as the laws of physics. And if we do this, this allows us to embark on a path of collective learning. So in our work, we deal extensively with human factors. So we recognize these physical limits, so with implications for ergonomics, health, and safety. Cognitive and emotional limits. For example, we all know about Dunbar's number. Many people are traumatized, etc. And this has real-world implications for psychological and cultural safety. And this in turn has multiple dimensions. So we're dealing with the diversity of cultures, ethnicities, religions. Then there's neurodivergence. There's the LGBTQIA rights movement. Then we've got all kinds of disabilities, and we subscribe to the social model of disability. So we recognize that in many cases, people are disabled by the environment around them. That's the most, and making sure that the environment is such that people are not disabled. That's the key challenge. Also for safety, I think we need to recognize that people come in all ages, and often in our discussions around healthcare, children are not necessarily given the voice that they should perhaps have, just as well as those who are older than 65. And all of this is in the wider context of exponential changes in communication technologies that we've seen. So here you see an overview going back through human evolutionary history. And right now we're at this point where AI, so-called AI, is becoming ubiquitous, where we've got machines imitating humans poorly, and where we have to deal with new interfaces that are introduced every day. And yet we live at human scale, at a small scale, within specific bioregions. We've got our households and our locales and our families, and we're embedded in this wider planetary scale. And on this planet, well, humans are not in control. We are part of the earth, and we can only understand what we can understand is actually very limited. And this is where collaboration comes in, and collective intelligence. So what is the Open Care Asia Platform Cooperative? It's intended to be a regional worker cooperative of digital health software experts and regional public health experts that connects health system funders with the professional software support needs of medical doctors, nurses, allied health professionals, and health care service administrators and their patients, their families, and communities, and with the collective domain expertise of leading international public health researchers and One Health researchers, and then connects this with healthcare needs and healthcare access needs of local communities, including indigenous communities and other minority groups. And then there's the important collective technological expertise in the developer communities around well-established open source e-health software like OpenMRS. And lastly, there's the community of health informaticians that maintain and develop international health data interoperability standards, such as HL7 FHIR and the International Patient Summary. So, since we're talking about a worker cooperative, we should talk about our values. So we intend to be cooperatively owned, democratically governed, and these so-called platform cooperatives are an alternative to venture capital funded platforms insofar as they are owned and governed by those who depend on them most. So that is the workers, the users, and other relevant stakeholders. And such cooperatives rely on democratic decision-making and shared platform ownership by workers and users. So in our case, users are healthcare delivery, service delivery organizations. We appreciate diversity as the fundamental building block for thriving communities. We elevate the voices of marginalized people as part of working towards equitable access to healthcare services and better health outcomes. We invest in people, in each other, and in trusted relationships with our funders, healthcare delivery organizations, and partners. And as importantly, in trusted relationships with members from marginalized groups that intersect our team, the teams of local healthcare delivery organizations, and the communities we engage with. And we consider local communities to be the most important source of knowledge and wisdom for health service design and allocation of limited resources. And I think this last point is nicely illustrated with the experiences that many of us, if not all of us, have made during the pandemic. In the words of Kiri Nuku from the New Zealand Nurses Organization, we've got to find a mechanism that we don't complicate access to services and diminish the quality of life just because of bureaucracy. We've got to make sure that we free up services to get to where they're needed. And I think this is where technology comes in, and reliable technology that's easy to use, easy to configure, that is highly available, and that doesn't that we can really depend on even in critical situations. So how do we do this? So the OCAPC initiative uses a multi-solving approach. So this means solving multiple problems at the same time via one set of complementary, mutually reinforcing threads. So we've got 6 threads going on here. So firstly, we are intending to fund a regional platform cooperative instead of purchasing unaffordable commercial solutions that are designed for North American and European markets. We prioritize the development of regional professional support services and a software as a service delivery model around existing open source health informatics software. So this gets to this point that around many open source software communities, there is a lack of professional support in the same way that vendors can afford to provide. And this is where this cooperative, I think, can make a real difference in providing the same, if not even a higher level of support than what people are used to from commercial vendors. We catalyze the adoption of open source health data interoperability standards with the help of developer communities from low income and lower middle income countries. So for example, we are connected to the OpenMRS community, and of course there are also further communities out there that we are open to collaborate with. We catalyze public health and disease prevention research initiatives in Asia and the Pacific, using regional specific insights to shape the priorities of this platform cooperative. We intend to staff the platform cooperative with members from indigenous communities and other minority groups to ensure that unmet healthcare needs and healthcare access needs are addressed, and reinforcing this by having those marginalized people within the team that operates and delivers these technologies. Lastly, we adopt an evolutionary design approach to product line management and engineering to achieve systematic reuse. So for us, reuse is not something nice to have. It is essential. It is the fundamental building block, and it allows us to achieve economies that are not achievable via any other approach. So what does this mean? I mean, we've introduced the notion of software product line engineering in previous webinars. If you're not familiar with this, then we encourage you to listen to those earlier webinars, but just briefly here to summarize, product line engineering goes beyond implementation projects. It goes also beyond traditional product development to a so-called product line mindset. And the difference to traditional products is outlined here in this slide. So it is when you've been developing products and using them or selling them, and once you start having more and more customers, that implementation projects, i.e. product configuration, can become a bottleneck due to the complexity and also often a limited number of people with critical configuration domain knowledge. When you start to feel that pain, then the product line approach can help, because there is a system for doing this. There's a method for simplifying configuration without losing configurability. Further pain points maybe product demand outstripping the ability to implement on time. So when implementation projects run overtime, product configuration costs then can become a pain point for customers. Inadequate product configurability can lead to a demand for customization, and as we then all know, customizations quickly lead us to variant and version hell. And this variant version hell can be successfully addressed via model-oriented commonality and variability analysis and the development of configuration tools that can be operated by customers. So this is what product line engineering is about. And then if there is demand, the product can now be adopted by customers with minimal need for implementation projects, because the configurability is intuitive and can be conducted by domain experts, by the people who are using the software. It doesn't require implementation technology knowledge to do the configuration. So our particular methodology for product line engineering is called model-oriented domain analysis and engineering. This is a systematic approach for conducting commonality and variability analysis and for sourcing and surfacing the domain knowledge needed to hide all the implementation details from users of configuration tools, so that these tools can be operated by customers. And we've been using this approach for over 20 years and refining it. We're not the only ones doing this, so this is a well understood discipline. The Software Engineering Institute from Carnegie Mellon University has been running this is now also, I think, over 20 years. For over 20 years, they've been collecting best practices. So it's always, you always need to have an architecture, so a core base of assets that are reusable, that are designed for reuse. So that is already different from your average enterprise architecture. Then you have a production plan. That means a well-defined way of using and reusing those assets. And you also have a well-understood notion of what are the variabilities and the commonalities. So that means you understand the scope, the use cases and the variability of these use cases in great detail. This approach involves taking a broad view, not only focusing on the user experience or on interoperability. In this approach, the human aspect is as important as these two other aspects. So we're looking at the ways in which humans learn, collaborate, and operate in healthcare environments. So there's an element of culture co-creation that needs to be tuned into the user experience that is being designed, and this in turn needs to be supported by appropriate interoperability standards. There are related books that exist out there on various aspects of what I just outlined. So, but now to get concrete, here we've got an overview of what we're doing with the Open Care Asia Platform Co-op. So this just shows you the overview as to how this all fits together. So the platform co-op is owned by workers and users, and it is governed, or it's supported by what we call the Open Care Metadata Community. So that's a broad community that relates also to AeHIN and the COIL network, with relevant domain expertise, where we source deep domain expertise from in order to inform the design of the platform. And again, we've explained how this all hangs together, what you see here on the slide in earlier webinars. So please watch those webinars. The message here that I just want to reiterate is that there is a dedicated process for platform engineering that is different from the so-called application engineering, which would be your usual product development process. So there's something below that that provides this foundation that enables systematic reuse. The other important thing is what you see here in this diagram is the professionalization of support. So, which is not a given if you're deciding to use open source software. Yes, there are professional support organizations around certain kinds of open source software, but we don't yet have this, we haven't seen this in health IT. So this is the innovation that we bring to this. With our expertise in product line engineering, we know how to professionalize support and to do this across all levels of support. So from the first level support to the second level of support, where you're then engaging with the engineering teams, and then the third level support where you're engaging with external parties. Now, making this more concrete, perhaps to something that you're familiar with. So here in this picture, you see how the Open Care Asia Platform Co-op interacts with the AeHIN COIL community. And you see that also how S23M fits in. So we are organized as a small worker co-op. We are distributed in the same way that AeHIN members are distributed. So even people who collaborate on a daily basis, like Keith and me. I mean, I'm here in Aotearoa, New Zealand. Keith is in Australia. So we're used to operating across time zones, and with virtual teams. Been doing this again for over 20 years. And this experience, we're bringing this to the Open Care Asia Platform Co-op. And what you can see here is that the Open Care Metadata community, with the domain expertise, that this is what connects us to AeHIN and other communities out there, for example, like the OpenMRS open source community, the FIRE development community, minority groups that exist in the jurisdictions that we're dealing with, and so forth. And at the other end, of course, we are conscious we need to connect with funders, which could be ministries of health, or it could be funding authorities at a smaller level, within large countries. So whatever the level of granularity is at which healthcare funding is distributed in particular jurisdictions. And of course, the customers are going to be health service providers in various jurisdictions, and there is a strong link there. All right, so where are we at today? So we are still at stage 1 of this initiative, and so now would be a good time for further jurisdictions to join. So far, we've been engaging with 3 jurisdictions in Mindanao in the Philippines, and have conducted an initial domain analysis. So what we want to, or where we're at now, is to gather committed support from 3 or 4 countries or jurisdictions within 3 or 4 countries, ideally. And so this gets to the reason also why we're running this webinar, is to tap into the collective AeHIN knowledge. So that means also your knowledge, to help us to connect with relevant partners and funders for this initiative. And even in case your country or jurisdiction is not yet ready to be a founding partner in the co-op, you can help us and find people and organizations in your network that are ready. And then the co-op's cellular organic expansion model will be ready for you when you need it. So we started conducting a domain analysis across 3 jurisdictions in the Philippines in December and January. And this is work in progress, and we would like to continue this work and to expand it to further jurisdictions, ideally from 3 countries in total, or even 4 countries. So that's what would make this really valuable for, well, then further countries, obviously, across Asia. We would like to see diversity so that this can then inform the work that we're doing. We're already seeing very interesting diversity across the 3 jurisdictions in Mindanao, and we can see how this diversity will encounter the same dimensions of variability very likely in other countries. But we'd like confirmation of that, and weaving your requirements or the requirements of your jurisdictions into this initiative would be very helpful at this point in time. The other thing that we're doing is incrementally developing a proposal for this platform called a formal proposal, so that we're ready to then establish the platform co-op as a legal entity later in 2025. So given the current time schedule, I would say, yeah, if we're able to establish the co-op in late 3rd quarter of this year or before end of the year, that would be great. That's our plan. So as part of this commonality and variability analysis, we are looking into the specific ways in which each of the following categories of users interact with medical record systems and digital health systems. So doctors, nurses, midwives, dentists, sanitation engineers, IT administrators, patients and their families. And there we have this diversity of culture, languages, different geographies, remote communities, etc. And then possibly further categories such as regional primary healthcare administrators, insurers, and so forth. In doing this analysis, yeah, we pay attention to obviously commonalities and differences that depend on local context parameters. So for example, yeah, whether we're dealing with urban sites that are on the lookout for interoperable systems, or rural sites that are in the same boat but have less available human resources, or we're encountering rural sites with strong catalysts. And there may be further factors that emerge during the analysis. And then we go further and we ask about the rates at which the work of each of the above roles, so in the previous slides, and each of these local context parameters tend to vary and change over time and over which time scale, because asking those kinds of questions allows us then to provide appropriate configuration tools to foresee basically what kinds of changes in configuration may occur or may be needed from time to time. For example, there may be some changes that follow seasonal patterns, other changes that reflect demographic changes that are in progress, such as urbanization, changes made possible by investments in internet and digital communication infrastructure, and so forth. So, yeah, currently we're dealing with 3 jurisdictions in Mindanao, and yeah, we would like to invite or encourage jurisdictions from further countries to join the initiative. This approach, amongst other things, allows participants from different countries to learn from each other and to gain a broader understanding of the space of possibilities. And on this basis, we then co-design these configuration tools that are adapted to the specific needs of participating jurisdictions, tapping into local domain-specific concepts that are tailored to the local cultural context. And then we can use advanced model-driven transformation tools to automate and simplify the configuration of vehicle record systems and other software. What's perhaps important to note is that all this structural information about how health services are delivered and how they operate in a particular jurisdiction, that information can be used to configure, say, OpenMRS, and the same information can be used to configure other software. So the idea is to capture this information in its raw form that is domain specific, accessible, and understandable to domain experts once, and then to automate from there onwards across multiple implementation technologies. Yeah, here we see again the overview diagram, and the slide just summarizes that we intend to further elaborate this proposal that we've already got in draft form since last September, I think, and which is now being complemented with the ongoing domain analysis results. From an architectural perspective, just a brief note here that when you're adopting a product line approach, you need to think beyond so-called enterprise architectures. There's this notion of a domain architecture, which is the architecture of all these reusable parts that are reused not only within one context, so within one jurisdiction, but also across jurisdictions. So that's where it gets interesting. A few words perhaps here on the open care metadata community, which is really, really important because the co-op can only do so many things, right? In the co-op, the intent is to build up product line engineering expertise and to bring together and formalize the domain knowledge from all participating jurisdictions. Now, the open care metadata community is a wider group that includes all the stakeholders who actively contribute relevant local perspectives, priorities, and domain knowledge. And this may include people from jurisdictions who are not yet part of the who are not yet using, say, software services from the, the co-op. And so this community acts as the steering group or the governance board for the Open Care Asia Platform Co-op. And here we see this close collaboration with AeHIN, which we greatly appreciate, as this allows us to break through the barriers of disciplines and organizational silos to power a continuous omnidirectional knowledge creation spiral. And so on the next 3 slides, we just want to give you an overview of what we've been doing in the Philippines, the 3 jurisdictions. So in Mindanao, so Iligan is the first jurisdiction. So this is a city region in which 6 to 7% of its population living in remote mountain areas, which make up 30% of the area. And the residents are tribal societies of Muslim or local religious faiths. These people are hard to reach, both due to inaccessible terrain, no public transportation, and military clashes with militia groups. And the next geography, there is South Cotabato, also in Mindanao. And so there we're dealing with 11 local governmental units that are geographically isolated. And there's only one highly urbanized area. There's one mixed list urbanized area, and then there are 2 municipalities with geographically isolated and disadvantaged areas with many indigenous populations. And yeah, on the slide here, you see further details of that have been surfaced by the analysis, so unique features of that geography. And then lastly, the third jurisdiction in Mindanao that we're engaging with is Zamboanga. So the health services there also serve southern islands known as ARM, which is an autonomous Muslim region. So unique challenges for Zamboanga arise out of large multi-ethnic population mix and geographic terrain problems. And so I don't want to dive into too much detail here. I think let's see who is attending. I think we've got, I'm not mistaken, we have a participant here, hopefully, from one of our friends in one of these jurisdictions, who may want to say a few words. I don't know. Not seeing anyone here. Maybe we'll do this in the Q&A. So, yeah, do this in the Q&A.
Yeah, Jorn, I think JL was in the meeting, but I'm not sure if he's with us anymore. So just move on to the Q&A and we'll see who's got something to say.
Yeah, good. We're nearly there. So just briefly then on the co-funding model of the initiative. So we actively, the co-funding model and is intended to encourage collaboration across Asia and with the diversity of co-funders. So the idea there is to provide a stable baseline level of funding that avoids the risk of depending on a single potentially volatile source of funding. So S23M and the Interoperability Lab in New Zealand, we coordinate this process with the guidance from the emerging AeHIN aligned open care metadata community. And we are doing this by scaling down our standard Australian, New Zealand fees to match income levels in participating countries. The costs for each participating jurisdictions go down as more participants join. So this is why also one reason why it's important to grow the number of participating jurisdictions, because this makes it very affordable for the participants and even also for the existing participants. The local costs for each participant healthcare service delivery organization are mostly in kind. That means in the form of making available appropriate staff and community stakeholders to weave local knowledge into domain analysis and platform design, and to integrate local legal and funding requirements for participating in the formal establishment later in 2025. How can jurisdictions join? And what is the process? So first of all, there is a time commitment, right, to provide local domain expertise to achieve the goals of domain analysis, and a commitment to establish a legal entity to employ co-op staff. So that's what we are looking for in jurisdictions, and to contribute to the seed funding that we need to continue the analysis and platform design over the next few months. So we're not talking big numbers here, just small numbers. This is before the platform is, before the co-op is established and then becomes operational later in the year. The multi-party co-funding model ensures that participation costs diminish in price when more jurisdictions join. And we've got a model where rebates are being given to existing participants as costs go down. We have reusable memorandums of understandings, as well as a draft formal project proposal for ministries of health and potential co-funders that provides a detailed roadmap and an operating model for the co-op. So a lot of work has already been done that we cannot possibly cover here in this short presentation. So we're building on these things, and the important work that still needs to be done is the surfacing of further local domain expertise, so that we can achieve this desired level of systematic reuse across all jurisdictions. So if you're interested in learning more, you're invited to contact our team. So my email address is there. And this leads us to the Q&A. I'm conscious we don't have too much time, so it's overdue. Let's kick off the Q&A. So here are just some suggestions that might prompt you to interact with us. But any questions you have is welcome. So we're keen to learn from you, with you, and hopefully get you excited about this initiative.
Thank you, Sir Jorn. To all our participants, you've already enabled the microphone. So if there are questions here that you can respond to, maybe you can start with unmuting your microphone.
I don't have a question. I'm just announcing myself as also being an S23M person that's working on this initiative. Unfortunately, John Paul Lemay from the Mindanao Health Service that's collaborating with us has dropped off the meeting. Otherwise, we would have asked him to give you an overview of how things are going with our collaboration. But as it says in the slides there, we very much appreciate people who are connected to their jurisdictions, to their local health providers, and to the funders and local governments that provide health IT services to them, to put us in touch with relevant people so that we can make the right connections to get this initiative going further. notice I've connected with a few people in the chat, so I'll follow up by email or LinkedIn messaging.
Aside from the questions on the screen, is there any question that you would like to ask our speakers?
Hi, I'm Dr. Veerabhadana from Sri Lanka Ministry of Health. I think it's a good initiative, but then there are sort of country differences how they operate, maybe especially on the funding side of, because we have free healthcare at the point of delivery, and the majority of healthcare is given by the delivered by the government. And 99% of the health budget is from the the government of Sri Lanka. So we do not have a mechanism as such to engage in this type of cooperatives. I mean, even we are part of the AeHIN. We have a coil lab in Sri Lanka as well, but it's mainly funded through private sector, small donations, stuff like that. So yeah, that's one challenge I see in moving forward, and the model is a little bit different. Like even when it comes to software, most of the software I mean the ministry or any or our government IT owns the source code, and we manage it ourselves. So I think there are country contextual differences. So I mean, I see good work being planned. Let's see how other people can join as well. Also, be mindful of the country context in doing so. Thank you.
Thanks very much. Yes, we're trying to learn as much about the contexts of countries that we haven't collaborated with before. So thank you. That's very useful information. We might contact you later and ask you a bit more.
Keith, maybe I'll just outline what we've encountered in the Philippines, where also, of course, healthcare service delivery is largely, or to a significant extent, public.
Yes.
That's exactly the context in which we intend to operate here. And just to perhaps reiterate, what we're intending to do here is to provide an alternative to commercial models from big vendors that are inappropriate, basically, for the countries in Asia. And what you just described there in Sri Lanka is a common alternative where the government or ministries of health develop their own software systems. Now, if you're part of that kind of model, you'll know what can be achieved with it and what can't be achieved with it, right? So, for example, the quality of the professional support around that kind of software, or the functionality and the interoperability, you'll know how quickly you run into limitations there. And then,
yes.
I mean, this is why communities like OpenMRS exist, and why in the Philippines then this kind of open source software is used as a starting point for in many jurisdictions for delivering some kind of health IT software.
Yes, exactly.
And this, again, it creates all these problems that we sort of touched on in this webinar, and we would encourage you to take a look at the earlier webinars where we explain some of these problems in more detail. What the reasons why these three communities in Mindanao got involved with this initiative is because they recognize all these problems and they see this potential for systematic reuse and for sharing the burden across more than one jurisdiction of professionalizing the support and having this explicit focus on systematic reuse. Another thing that's, I think, worthwhile commenting on is any reliance on a single funding source can be problematic, as we've been seeing recently with the loss of US aid funding.
Yeah,
So
that is
we-
something that's impacted on this project as directly as well, because the Mindanao people were intending to use US aid funding they thought they had access to this year, but now that's not there anymore. So we have to, we're investigating outside of AeHIN with other funding partners, and we're also asking for intelligence from within the network to see what other people are doing in the absence of US aid. So yeah, anyone who has any thoughts to share with us, please get in touch. And yeah, we're also, I mean, trying to just we're trying to get things off the ground in the immediate term, but we're also trying to align people's thinking across the AeHIN network so that we can be set up to have further countries join us once things are off the ground if they see a potential in migrating from sort of private source code like you have in the government in Sri Lanka, and like they have in the Philippines as well. They've got a lot of Ministry of Health source code which is available across the health services in the Philippines, but it's there's limitations to the support, the documentation, the maintenance of that in context when it's used. So that's, as you can see, that's why we want to raise the level of reuse and the level of sharing of common resources across a configuration that's applicable in multiple places. And if we can't get people on board in the first founding partner group, hopefully we can talk about longer medium-term planning, which different jurisdictions have, so they can join in a longer-term time frame. Thank you, Chaminda. That was a very useful summary of your situation.
Yes, thank you once again, Sir Jorn and Sir Keith, for sharing about your work with the AeHIN community. Thank you as well, everyone, for joining this special schedule today. All right, thank you, everyone.
Bye.
Bye.